Hi, I'm John Stevens,
This is Matt Russell.
and this is Pod Have Mercy.
This is Pod Have Mercy.
Oh, I'm John Stevens, and I'm here with Matt Russell. And today, I am really excited about this podcast because we're going to be talking with Dr. Marc Boom, who's the president and CEO of Methodist Hospital. And I've been really blessed and fortunate to be on some calls with him, with the Texas Methodist pastors and some leaders in Houston a couple of times. And I thought it would be really helpful to invite him to join us and just ask some questions. We've given people out in the social media world the opportunity to ask questions that we could communicate with him. I'll tell you, Marc is a really impressive individual. Houston Methodist is one of the 100 best companies to work for. It's been rated one of the top hospitals in the U.S. by U.S. News and World Report. And not only is he the president and CEO of the hospital, he also has an internal medicine. He still practices medicine on the side.
That's amazing.
In a little office and sees people from time to time. One of the things that I think will be interesting to hear from him is that he is on a call every morning with the heads, the presidents, the CEOs of all of the hospitals and institutions that are a part of what's called the Texas Medical Center. The Texas Medical Center here in Houston is the largest medical center in the world. It has 49 institutional partners.
Amazing.
And so they are really at the cutting edge. And not long ago, actually about a week ago, Houston Methodist made national news as they were engaged in this plasma therapy with coronavirus patients. So I'm really excited that he will be able to share some thought with us, and I really look forward to just hearing from him.
Yeah. We're really fortunate to be in a city with folks like Marc in it, and is doing this kind of cutting edge work and leading this cutting edge work, and in a denomination that is, our root systems are in the health of the common good. And so to have a hospital like this in the heart of the city and state, there's something about that. Although I'm not doing anything about it, I know good folks are doing things about it. A lot smarter folks than I am.
Well, the great thing about Houston Methodist, it's an outreach ministry of the Methodist Church through our conference, and it's been around for 100 years. It actually started in 1919 with the Spanish influenza outbreak.
I didn't know that.
Yeah, yeah. So it's interesting that the hospital began as a response to a pandemic, and now we find ourselves in these days.
Yeah.
Hello.
Hey,
Greetings. Are y'all able to see me okay?
I can.
Yes,
Yeah, you look
amazing.
great.
Y'all too. You look so comfortable there.
In our little studio,
Yeah, very nice.
in our bunker.
Yeah, I feel a bit like that too.
Marc, I want to really thank you for being with us just a little time.
My pleasure.
I really want to just tell you, I benefited a lot from those early calls that we had where we were able to call in with Bishop Jones and with other Methodist pastors. And that really put my mind in the right place to know that it was the right thing to do to talk about not holding church services for us at Chapelwood. And your resource, your conversation, along with Dr. Drews, I think was on the call, was very, very helpful. Good. And so we've already done a little bit of this where I've introduced people. You are the president and CEO of Houston Methodist. And one of the things that I think would be very interesting to hear is you are on a call, my understanding is, either every day or most days with the heads of the Texas Medical Center, which, if people are not aware of it, it's the largest medical center in the world, 49 member institutions, MD Anderson, Texas Children, so on and so on. But I think you're in a place where you can give us, like, where are we now with this? Sure. I think people are familiar with it, but where are we now, especially in the U.S. and in Houston particularly?
Sure, happy to talk about that, and thanks. Yeah, actually,
Yesterday was the first day we took a break from our 7 a.m. call in probably 3+ weeks, which we all welcomed, but kicked right back in this morning. And it's actually a call among about 10 or so of the institutions. So Houston Methodist, CHI St. Luke's, Memorial Hermann, Texas Children's, MD Anderson, Harris Health, Texas A&M, UTMB, Baylor College of Medicine, UT Health Science Center here in town. And I think I got the whole list. I apologize if I left anybody off as I go from memory. But and it's a great group, and we're collaborating really, really effectively and well. And it's a very unprecedented situation, obviously. Yeah. We always collaborate well during hurricanes, but even in my own system, which is 8 hospitals spread out through all of Houston, oftentimes what's happening, in one part of town is very different from another part of town, and a lot of sort of decentralized decision making. For this, centralized decision making makes a lot more sense, both in terms of my own institution, our own institution, as well as we collaborate and coordinate across the Texas Medical Center institutions. So let me give you kind of the Houston Methodist numbers as sort of a proxy. I will say, as we look at across all of the institutions, we're seeing similar trend lines. So if we roll back now, all of a sudden getting to be not quite a month ago, but we go back to March 11th, 12th, which is right when the first community spread happened in Houston, we had 3 or 4 patients in one of our hospitals. Put that in perspective, we run about 1,900 beds a day. Some of those are medical surgical beds, around 1,100 of those, about 300 plus are ICU beds, and then the rest are neonatal intensive care and a bunch of other obstetrics and other areas that are not really appropriate for this purpose. So the number we've been watching is really 1,450, 1,500 beds that are our traditional capacity. And back then we had 3 or 4 patients in-house. They were all travelers. Today we have 147, I believe the last number was, I saw an hour or two ago. So still about 10% of our overall adult capacity, but sort of ramping up day after day after day. And keep in mind, on a normal day, we're 85% full. So, it's not like all that capacity is sitting there available. What we did was we stopped elective procedures, did a lot of other techniques to bring our census down. And so now our overall census is in the 72, 73% range. But if I took ICU, which is really where the crunch could potentially happen, 30+% of our ICU capacity is for patients with COVID or suspected COVID at the present time. Mm-hmm. We managed to kind of get it down to about 45% capacity without COVID. So, we're about 3/4 of our capacity now and ramping up each day. So we have lots of strategies in place to increase that as need be. On the good side, the line we're seeing right now much more approximates a linear trend going up rather than an exponential trend, which is reassuring. But nonetheless, it's still a trend and it's still going upwards. And so we're watching that very closely. And I can talk about modeling and some other things that we're all doing. And you could impute sort of similar numbers across the Texas Medical Center as a whole. Houston Methodist has about 20% market share for the adult population in Houston. So, roughly 5x if you want to look at the entire population of Houston across all the different hospitals on the numbers I would quote.
Yeah. Well, Mark, I don't know if you've ever met the Reverend Dr. Matt Russell. He's one of our executive pastors here and does a lot in the Houston community. He has for a lot of years. He was at St. Paul's for a while, so he was down close to you guys. Yeah. But he's been doing this podcast with me, and I know he had a couple of questions to ask as well.
Yeah. First of all, thank you so much for the work that you're doing. And it's just, John and I were talking offline how, what a blessing it is to have you in this community and the work that you're spearheading. One of the things that John and I did was to kind of put out on social media, just letting folks ask some questions and what questions we'd want to ask of you. And a couple of them were, one, how long will the social distancing last? And then the other was, should we be wearing masks at this time? I know the CDC has put out some things. And what are some of your recommendations along those lines?
Sure. I wish I knew the exact answer to the first one, but I'll give you my best cut at it. It's going to be with us for a while. When we look at, and this will be one of the key messages everybody should take away from today, social distancing is critical to saving lives, to making sure that we don't end up with a situation where, this spreads literally out of control, because it truly gets out of control. At some point, it's unstoppable and it overwhelms everything. And of course, we've seen markets where it has done that, but quite frankly, could even be worse than that if things are not controlled. And so that social distancing is really key. So the answer to that question, to a certain extent depends on how well we socially distance. If we do a really good job, sort of rip the Band-Aid off, take all the sacrifice and all the challenges that we're going through and do that right, it's shorter than if we don't, when we look at all of the modeling. And so that's one really fundamental issue. And I think from looking around the community, we've done a pretty good job, but not as good a job as we could do. There's, it's a tough thing to measure, of course, but there's cell phone data that people look at, and we get a D as a community on their grading scale as to how much diminishment we've seen.
Wow.
And so that's going to be a key fundamental thing. One key also, whereas we may on the downside of this slope emerge to a new normal, it is not going to be normal, quote unquote, the way we used to see it. There's going to be an extended period of time where kind of the rules of how we live are going to be quite different. None of us know exactly what that looks like, but I think we should expect that vulnerable populations will still stay somewhat isolated. I think we should expect that not social distancing as in stay home, don't go to work, but social distancing in terms of the practices we have are going to be quite different. On your masking question, really the theory around that continues to evolve and the data around that continues to evolve. CDC is now suggesting that people wear masks when they're in public, like going to the grocery store, other places like that. The rationale really is less about, if I'm going to the grocery store and I put a mask on, it's less about protecting myself. There may be some degree of that, but the main degree of this is protecting me when I'm wearing the mask from accidentally infecting others and infecting surfaces there. Because if I'm early and let's say I have the disease, I don't know it, I'm in a 2 or 3 day period before I'm symptomatic, and I may already have the disease, but I'm not symptomatic, or maybe 20 or 25% of people are asymptomatic, and so they don't even know they have it. That if I cough, if I clear my throat, if I sneeze, if I, allergy season, everything else for other reasons, I might unwittingly, put droplets someplace, somebody touches their eye, touches their nose, touches their mouth, and they may infect themselves. And so with everybody wearing a mask, that should decrease that spread. And frankly, also, as long as somebody's not, messing around with their mask, which is one of the challenges with masks, people tend to put their hands to their face even more often when they wear a mask. And that's a challenge with it. But if people can learn like we all did, I still remember medical school when I started wearing a mask and scrubbing into surgeries and how hard it was not to, you're sterile, you're not allowed to touch anything. And, you'd sit there and your nose is itching and you just sit prepping it for 5 minutes waiting for it to go away. We all have to kind of learn to do that and be real conscious of not doing those things. So again, masks are now recommended by the CDC. Not everybody's wearing them, but it is useful. We've chosen in the healthcare environment to go to universal masking as well in the clinical areas to protect our patients. So all staff are wearing a mask in a clinical environment, not necessarily in some of the back office environments.
So Mark, back on the social distancing, you say in Houston gets a D. That's not a passing grade.
No. When I went to school, I would have never made it home alive with my parents.
Right. But
on the weekend, it's getting to a C, but basically they're looking at distances. And, this caveat this, right? This is distances cell phones are traveling, and certainly some markets are more spread out and everything else, but it looks at how much does each individual, and then they aggregate the data. It's much in the way, Waze or other things like that work, and looks at how much diminishment has there been. And you're seeing about a 40-45% decrease, which is really good. And I could argue theoretically that on top of that, so that's already suggesting there's distancing. Of course, people aren't going to the grocery store, and when they do, they're using a lot of safe techniques. And hopefully when they're at their employer, if they're still in a business that's working, they're using a lot of other things. So there's more to it than that, but it still suggests that we're probably not quite as effective as we need to be.
There's a mindset from some people I talk to, and I know a lot of people in oil and gas, and that's struggling now. The economy is struggling. So you're hearing a lot of people saying, looking at our community, we're not New York, we're not Detroit, we're not New Orleans. And there's a false sense of security, it seems like, that people think, well, Houston's not going to get it that bad. So maybe we can go back to work. Maybe this is overblown. Maybe this is these pockets, but not going to be everywhere like this. What do you say to people who say that or believe that?
Well, I think without a doubt, the virus is here. It's spreading in our community. I mean, we see evidence, if I look at our data of more and more people testing positive. Now, some of that gets, messy to look at because more testing availability is there.
Sure.
But of those who are being tested, a higher percentage of them are positive, which shouts out to me that the prevalence,
It's growing.
how many people in the community have the disease, is higher. And we're seeing that march up pretty significantly. So we know it's here. We know it's spreading. It's simple math. If we don't do these things, that will overwhelm us, period. And so until we get to the backside and see this curve going down and then have judicious ways to sort of release some of the restrictions, that would be devastating, frankly. We will see, a rapid, and once true exponential spread at a later part of the curve gets out of hand. I mean, if you look on aggregate across the world right now, it's an exponential spread. Look at the curve line. I mean, you're adding 100,000 people a day around the world who are infected. We don't want to see that in our population. New York City has 120,000 or something like that infected already. We don't want to see that. And we can keep that down if we all work together. But if we don't, and we go back too soon and we release too soon, that's what's going to happen. And ultimately, as hard as this is economically for everybody, that's going to be much more devastating economically if we are shut down to that degree. Now, there's a balance, and I'm the first to agree with that. And of course, my role is health. So, I'm going to be in the health lane, advocating for the health side. I just got off a call with the business community. There's a strong consensus that we need to do more. We need to do better right now to stop this so that we can get back to work and we can get back to work more quickly, because otherwise this will be very prolonged.
So what I hear you saying is we need to do as much as possible in the short term. That gets us back to whatever the new normal is quicker, as far as the economy and the oil and gas and all that moving again. That if we half play at this, that's the danger that it gets spread out even longer. Correct.
Exactly.
Go ahead.
When we think of the cities around the country that are kind of the epicenter of this, New York, Detroit, some of the conversations that folks are having is that they're being overwhelmed with just the healthcare system is being overwhelmed. There's not enough masks or equipment or those kinds of things. How are y'all doing in that regard? Where y'all are at?
I can speak for us, but I can speak across the Texas Medical Center. Fast and furiously, we've all been working on making sure that we have the appropriate safety gear. I mean, safety comes number one in what we do, and protecting our staff and having that in place is number one. I feel pretty good about where we are. Lots of creativity, both in terms of securing the supplies as well as then using the supplies, as effectively and smartly as we possibly can. Reuse opportunities with sterilization techniques and a number of other things, and a lot of really creative solutions to lessen the use. Like our folks created an intubation box. So intubating is when you're putting a breathing tube down someone's throat or down someone's airways to breathe for them. Well, for the person performing the procedure, that is a very risky procedure, because that's right there, generating a cough. You have aerosolization of some of the materials in their mouth and their nose, meaning the virus, etc. So they created a plexiglass box that can literally go over the patient's head with holes in it for the person to work on, and negative pressure basically sucking out the contents within the box. So it doesn't eliminate the need for PPE, the personal protective equipment. In fact, they will continue to use it. It's a whole nother layer of protection. We have I call it it's almost a phone booth on wheels. It's a plexiglass phone booth with depending on the use, there's one that has some holes in it for some of those arms to use, or the other one literally looks like a phone booth, because a nurse may need to go into the ICU room where the patient is, simply to adjust a ventilator setting or to adjust a setting on an IV fluids or things. And every time to gown up and glove up and everything else uses a lot of PPE, but it's also very time consuming. So now they actually have this little plexiglass phone booth, and they'll roll in and they can go tweak it because they have complete barrier protection from what you'd be concerned about, and then roll back out. So lots of good old American ingenuity.
That's great. So, Mark, recently, Houston Methodist made news, national news, with this plasma therapy. Can you explain? There were a couple of questions people had, not only how are patients responding, I think explain what it is, but how are the patients responding to it? And then some people were even asking if they've had it, how could they be of help to you in this process?
Sure, it's something we're very cautiously excited about it, and I want to temper a little bit of the excitement to make sure people understand this is it's a research project right now. There's good theoretical reasons for it to work, but we need to sort through those. So, what this is, it's a very old technique, and if you look at Houston Methodist, we were founded in 1919 during the Spanish flu pandemic, and people used this technique during the Spanish flu pandemic. And what it is if I get some sort of illness, my infectious disease, my body is going to make antibodies to that infectious disease, usually showing up one kind of antibody in the relatively short term and another kind in the long term. And it's actually a type of testing we use all the time at trying to sort out where people are in certain infections, hepatitis, and a number of other infections that we do. So the idea here is that between those antibodies and possibly some other factors in the liquid part of the blood, what we'd call it the plasma of the blood or the serum. Those are slightly different things, but basically the same idea, which is the liquid part of the blood. All of these things are circulating there. And so if you can take that from somebody who's a couple weeks out from an infection and they've formed all those antibodies and other factors, then give them to somebody with the illness, that may help them. So what we did was we got emergency approval from the FDA to attempt that in a couple of quite ill patients. We've now done a whole host of those patients over the last 7, 8, 9 days. Started with 2, not this past weekend, but the weekend before. And we're cautiously optimistic by what we're seeing. These are really sick patients, so there's a whole bunch of other things being done to try to help them. So sorting out exactly is it working or not is not an easy thing to do, but we're cautiously optimistic. Very importantly, this is all the precursor to what's just kicking off across many, many institutions around the country. We're collaborating with Baylor College of Medicine here also in the Texas Medical Center. And that's a multi-center randomized controlled trial of this to really understand its safety and its efficacy. If it works, and the other piece right now, it's being used in sick people, really sick people, but there's 2 other potential uses. One would be in healthcare workers or other frontline people as a preventative measure. And there's other types of situations where we give some kind of passive immunity that way to people who are potentially being exposed. And the other might be in sick people in an acute care hospital bed to prevent them from, maybe with some sort of indicators. That's what we'd have to sort out. Who's at highest risk of declining and ending up needing ICU care, and then trying to prevent them from declining and going into the ICU. If all of that works through the study, then theoretically, at least, we collectively, the medical profession, can actually manufacture the antibodies that are working, and that could become a very scalable treatment. Wow. Where we're hoping is that, hopefully, of course, it helps people who are critically ill, but the real huge hope I have is that it helps people who get sick come to the hospital and keeps them from getting really, really sick and going in the ICU. Obviously, that would save lives. Yeah. But also when we think about how to turn back on the world, if we knew that, okay, some people are going to get sick, but we'll get them in the hospital and we can prevent them from getting really sick and dying and needing ICU beds and everything else, that would dramatically change this calculus, right? I mean, if this disease, instead of having a 1.4% mortality, had a 0.1% mortality like the regular flu, or even lower, it would change the whole dynamic pretty dramatically. And so there's a lot of hope for that and other treatments in the earlier phases, leading up to a vaccine ultimately as the what could finally sort of put the stake in this.
So if someone had COVID, they tested and they've recovered positive, if they are willing to help, are you looking for people like that? Okay.
Absolutely. Okay. And I can easily get you a flyer that we have with the phone number to call. People have to be a couple weeks post, a documented infection of COVID. They can't have a whole bunch of other underlying health conditions. So they have to otherwise be relatively healthy. And then they'll undergo testing to make sure that, indeed the antibodies are there and we can test for the effectiveness of that. And then it's just like sitting there and giving a blood donation. You sit there for about an hour and they pull off this plasma from you. One donation can treat 2 patients, and people can, because it's not a high volume like a blood donation would be, you can actually donate twice a week. So
Wow.
one individual can help 4, potentially help 4
fantastic.
other.
That is great.
Very, very excited about this. So I'm happy to get that forward over to y'all that you can share with your
that'd be great.
listener, your congregation. So thank you.
Yeah.
That's great.
One of the things also, somebody asked us about this more recent stuff that came out about, there's the droplet thing, and now there's this Aerosol Bio Aerosol that it can exist in the air. Should people be concerned about that? Is that where the wearing the masks now more often, is that where that comes from? Or is this I don't even know how to say it, aerosolization?
Very good. Yeah.
I came close. I broke it up in small pieces. I can do that. What are you hearing about that?
Yeah, so there's been a couple smaller studies. They've been criticized a little for their methodology. There's also always the question of sort of clinical meaningfulness. Really, the preponderance of data still suggests that this is droplet spread, and that the reason for masks is to block the droplet transmission, et cetera. That's not to say in certain unique situations there couldn't be some more aerosolization of this. Certainly in high risk settings like a hospital setting where you are intubating somebody, where you're doing procedures, you can actually create that aerosolization, and that's why sometimes there's higher risk for it. But there's pretty darn good science around the 6 feet. It's nothing, of course, nothing's 100%. This is an evolving situation. It's a virus we haven't dealt with before, but there doesn't appear to be anything dramatically different from that standpoint from the flu or many other respiratory viruses that are spread through droplet transmission. So the science still really supports the 6 foot distancing, wearing a mask. I mean, look, you can't go wrong if you have a simple mask, to wear in public like that. It really don't see probable harm other than the messing with your face kind of thing. If you put it on and the next thing you know, you're constantly adjusting and messing with it, I mean, you have the possibility for self-inoculating even more than you would have if you didn't wear the mask. So you have to really control that in the same setting. I mean, if I go to the supermarket without a mask on, and I obviously have to handle groceries and other things, but I'm doing my hand hygiene effectively. I leave do that right after I load the groceries in my car. Pretty much told somebody I went to the grocery store the other day, I probably did my hand gel 15 times through the course of that experience, which is the right thing to do.
Yeah.
That's probably safe. If I go there and I wear a mask and now it's bugging me and I'm handling all these groceries and now I'm up there fiddling with the mask over and over again, I worry about that actually is causing risk to me as the wearer of the mask. So you really have to manage those sort of behaviors and be very cognizant of it. As I joked, but it really was true. As medical students, we all sort of learned how to, be sterile and not mess with these things. And it's not easy. Your nose will itch, your mouth will itch. We all have this habit of touching our face all the time. So
that's actually great advice for lay people when it comes to medical stuff, is that you're wearing a mask and you could actually be touching your face more. And thinking the mask is helping you, and actually it's
right.
not. You're defeating the purpose.
If I've just touched a contaminated surface and I'm not wearing a mask and I'm really good at not touching my face, versus I'm wearing a mask and I touch a contaminated surface and now I'm fiddling with the mask, I actually think there's good cause to think that could be worse. So you have to balance all that. On balance, if you don't touch your face, I think the masks can be helpful in public, as the CDC is recommending, because I'm not going to accidentally infect surfaces that you might come behind me and touch. But again, that's probably the bigger mechanism, not me being protected by the mask, but us all sort of as that social compact, protecting each other by wearing a mask.
That's great.
Matt, you got a question?
Yeah, I'm wondering today, what are you on your radar? Are you most concerned about? And then also, where are you finding the most hope?
Thanks. That's a great question. Really the main concern is rate of spread. And if this gets out of control, that's why we were all doing all these things to really urge everybody to play their role. I mean, this is we're all in it together kind of situation for sure. With that, I have a lot of hope too, because I think humans are pulling together. I mean, obviously we see some negatives out there. We always will when a crisis hits, but by and large, crises like this bring out the best in everybody, whether that's watching our employees here do wonderful things, or whether it's watching the community rally together and, all the different things done to help bring PPE to hospitals or support hospital workers or support the frontline emergency care workers, and people really doing their role is something that, certainly gives me a great deal of hope and appreciation, frankly.
Somebody asked about testing. There's been a lot of debate about testing, and there's been a lot of blaming about testing and not having enough testing. How are we doing in Houston as it relates to testing? And will there be tests at some point that can either be self-administered or a blood test or something that has a faster result than maybe now I hear different stories that we have a 15-minute test and some that takes 2 weeks to get, or a week or whatever, to get back.
Sure. So the standard testing right now is what's called PCR. It's you do a nasal swab or a nasopharyngeal swab in the back of the nose and throat, and through essentially amplification mechanism, they look for tiny bits of genetic material. That test in and of itself takes several hours to perform, and then logistically, once you have to figure out collecting the sample, delivering the sample, et cetera, it takes longer. So across our system, where we're doing this in one location, that's about a 15-16 hour turnaround internally to do that, which is actually about as good as you can get it. I mean, short of, if I had one sample, I could walk it there and I could probably do it in 4 hours, but we batch them and a bunch of other issues like that. The sending out tests, and that's what most people are getting in the community right now, are problematic really because of backlog of LabCorp, Quest, a lot of the national testing organizations, because they're overwhelmed.
Yeah.
They're just getting massive numbers of this. And so you're seeing 3-4 day turnaround time, which if you're a patient at home and you're going to be quarantined anyway, and you're not really particularly sick, is far less than ideal. You'd of course like to get the answer, but from a clinical perspective, it may not actually matter that much. Again, we'd like to do it quickly, let me be clear, but may not have relevance clinically. Whereas in the hospital setting, you really need to know, are you dealing with it or not, for a whole host of reasons. So then there are other types of testing that are coming out, running the gamut from, a 5-minute test where you can get a 5-minute positive and about a 15-minute negative. So, it's not mass capability. You've also got some equipment that's getting released where it's much more automated, so that it's still a pretty manual process, what I described for the 16 hours or so. That'll speed things up dramatically, and you can do much larger scale testing. So you'll see institutions like ours, I heard this from UT just on a previous call today, where we think within a matter of a couple of weeks, we hopefully can get to thousands of testing capacity a day, and we can see the community do that as well. Where it's going to mainly be relevant is as we think about getting out of this situation, testing has to be a huge part of that. We need to be able to very quickly get results, very quickly follow up on results. We'll be playing, I think, this game of, kind of whack-a-mole kind of deal where, you're going to see a small outbreak and you have to figure out how to follow it, maybe in very local areas, do some quarantining and other things, and then you're going to go over here and do it again. And to do that, you have to have massive testing capability. You also have to have a very large public health infrastructure. So that's going to be an area where a lot of investment, I think, has to follow. If you look at Texas and you look at testing per, 1 million people, or testing per 100,000, whatever your benchmark is, we're in the bottom 5 to 8 in the country. The United States, up until a week or so ago, was way behind the rest of the world. We've been catching up, but that's especially because of the mass testing that's really started in places where the outbreak is particularly severe. Texas is still lagging as a whole behind much of the rest of the country on that one.
Yeah,
I think you'll see that change a lot over the next couple of weeks, but we're still behind.
Is that have to do with just the resources that we have deployed to that? What's the reason for the lag on those testing? On the testing? It's
really the fact that if you go back 3 months ago, the kind of public health infrastructure across the country, with the CDC stood up a test of their own. You've read all this, but they had problems with that. It slowed things down. They didn't ramp it up. What we did, we did our first test on a trial run basis, not a patient with symptoms, but as a trial, in January. So we had it internally in January and started turning it on, solid 3 weeks ago. Frankly, we could do far more tests than we do today if we just had more equipment and more reagents and some other things, but those have all been on very short supply nationally. So we're running, 250, 300 tests a day now. So it's a very solid number. Like I said, everybody who needs to be treated, who's coming to us, needs to be treated, but that's a selected population. When I mean that, it's people who are sicker, who've already passed a screen with their physicians. They're coming in, getting tested. So, actually we're probably admitting 40 to 50% of those individuals who get tested actually get admitted into the hospital.
Someone also
not who get tested positive, of course.
Oh, okay. Yeah. Someone also said they had read a study somewhere, I guess, I think Johns Hopkins, about Italy and New York City, the hospital systems, and becoming overwhelmed had to do with they were using, the way they put it was conventional intake processes, but this is an unconventional situation. And I guess, they were asking, as it relates to a pandemic, how are you at Methodist and the other hospitals thinking in terms of operating differently? I don't know if this is connected to these pop-up hospitals that they're putting in convention centers, if that's connected to this conventional versus pandemic type way of doing things. But can you speak to any of that?
Sure. So, in terms of it's kind of a bifurcated question. Let me get the front end, which is, when one comes to one of our emergency care centers now, there is a front line intake process where people really get bifurcated into, okay, you need to go down a path of being evaluated for COVID, or you are here for some other reason, and there's no reason, on a quick screen to think that you might have COVID. Of course, the higher the prevalence of the disease in the community, the more people who may be coming in for something else who may also have COVID. So that's something we're watching closely. So that's handled very differently than in regular, quote unquote, regular times. Yeah. We've done this with H1N1 and other times where the flu has been particularly significant. The other question really comes down to what I'd call surge capacity, which is, right now, as I mentioned earlier, we're using about 30% of our ICU beds for patients with COVID or who are being tested for COVID. We have about 45% of our ICU beds are being used for other purposes, which is far down from the 75, 80% we usually have. But we turned off all of our routine care and surgeries and a bunch of other things to do that. So we still have about 25% of our typical ICU capacity available to surge into COVID, which on the curve we're seeing that's going to be a matter of days before we use that, maybe a week, if we don't see an acceleration. We have plans then in place where we could literally double that capacity, and that's by taking lots of other sites of care. So, if when you go to surgery, you might be in a pre-anesthesia area where they're actually, starting to give you some of the drugs and get you ready for surgery and other things. Or you might come into a recovery room after surgery. Well, We're doing, less than half as many surgeries as we would normally do, far less even on the outpatient side, again, for bring up capacity. And so a lot of those areas can turn into ICU space, et cetera, et cetera. And so we can, easily is too strong a word, but fairly promptly and without too much extreme difficulty, probably double our ICU capacity. Now there's staffing issues, many other issues. It's not easy at all. And so that allows a great deal more surge. But after that, you have to really get creative internally in what I call surge in place. And then after that, you have this issue of, do we need additional hospital capacity outside, which are the field hospitals, convention centers, all of those kinds of things. There's active work going on at the county and city, working in collaboration with the hospitals and planning those kinds of things. Knock wood, we're not there yet, and I sure hope and pray we never have to go there. But of course, we're preparing for all eventualities. I think this next 7 to 10 days, when we see what curve line are we on, versus some of the modeling will tell us whether we can get by with, for example, a doubling or a doubling and a half of ICU capacity within the institutions without needing those, or whether we truly have a problem and have to go more broadly than that. We just don't know the answer to that.
You kind of asked the next question. For Houston, I've seen different things. You said maybe the next week. I know there's been talk on the news. We're at April 6th today. What is today? We already talked about how time is irrelevant these days. It's just every day is the same. It's like Groundhog Day. But and then I've heard that it won't be till May 6th that Houston sees its peak of the apex. And so we see New York is having that. Detroit, these big cities are hitting the surge that needs all this other field hospitals and everything else.
Yep.
Do you have a modeling or a timeline of thought of as far as Houston or Texas? Are we still on the upswing? And what do you see as sort of the top of this curve for us?
Yeah, we most definitely are still on the upswing. No question about that. Lots of models out there. They are directionally consistent, but of course, a model is just that. It's a model, and I mean, every single model is wrong by definition, right? Because none of us have a crystal ball. But one of them is going to end up being better than some other. It's like predicting the stock market, right? People can always look at it and afterwards they're like, oh, look how good our model was, right? But then there were 90 other ones that weren't so great. But if you look at some of the main modeling sites, one of the ones we use a lot from a more aggregate basis externally is University of Washington IHME site. You can Google that and find it. It's a very reputable site that has state-by-state data. Now, when I pulled up their state-by-state data for Texas on Friday, it was telling us a March 6th, if my memory serves correctly, peak. And when I pull it up today, it's telling us something like an April 17th peak at a much lower peak. So that's actually a good thing. Good. But it's gone back and forth based on, what they're seeing. So that's a very broad level one. That's Texas-wide. We have a couple models. UT School of Public Health, Dr. Eric Boerwinkle has been very active in doing modeling for Houston. His most recent model suggested a peak towards the end of the month. Cumulatively by that peak, about 62,000 cases in the city. So put that in perspective, we're 22,000 something that are known at the present time. I think that's underestimated by a factor of at least 2 or 3. So let's say that maybe there's 5,000 or 6,000 cumulative cases. So you're looking at a lot more cases and a lot more pressure on the hospitals in that model. And that one then tails out to about mid-June up to about 110,000, 115,000 cases. But the tail, kind of gets small. And while we're on that down tick of the tail, there should be some strategies to start normalizing. We have an internal model within the Texas Medical Center that looks at how are we tracking other cities. And right now we are very parallel with New York, with Lombardy, Italy, with others. Now parallel, we're a little lower on a normalized basis, but the rate of increase is no different. And what we saw in New York was, a week, 10 days ago, and we're about 10, 11, 12 days behind them, they sort of broke their curve. And that was one of the challenges. So they were tracking along and then it really accelerated. So we don't have an answer yet as to which curve will we follow here. That model goes anywhere from about 2% of the population getting infected and numbers that are very challenging, but we'll manage through them for the hospitals, up to 13 to 15% being infected, which is, very, very challenging. And needing field hospitals and everything else. The fundamental thing is the social distancing following everything that's happening to keep us down on that 2% curve, maybe even lower than 2% curve. And we're going to be okay. I mean, it's going to be a challenging month for sure, but we're going to be okay. And
so, that just, to stay hopeful and positive, when I hear that, you can immediately go to the dark places in your mind and think about all the bad. But it also is a warning to not be complacent that all this is happening in these other places, and we seem to be okay in Houston.
Yeah.
And that's not the time that you start to loosen up and become careless, or else that surge then really, like you said, could take off.
Yeah, well said. And my biggest fear, honestly, is at some point we all look at the data and go, oh, that doesn't look as bad as we thought. And we sort of wildly and carelessly release the restrictions. And then we have a massive bounce back in a way that is completely out of control. And all that we've done this last, few weeks and a few more is almost it's not for naught, because we will have controlled it during that time. But then we have the whole same thing start again. It's going to be really important. If we're sitting there celebrating the fact that our curve didn't look like New York or New Orleans or Detroit, that's going to be because we did the right things as a community, and then we have to continue to do the right things to kind of ease out of those restrictions, or we're just going to go back and look like that. And that's honestly my biggest fear. We've said oftentimes as a group of CEOs, look, if people criticize us at the end for being, oh, wow, this didn't turn out that bad, and they criticize us that we were overly worried, frankly, that we will have succeeded, because at that point we're going to look at it and say, yeah, the reason it feels that way is because we did all the right things and didn't end up on that other curve.
I agree.
It seems so important to be listening to the medical professionals at this time, right? There seems to be so much opinion that's there, and when I listen to you and to other medical experts, it seems to be the same thing over and over and over, which is physically distancing and acting with a lot of precaution in these days to come. And that's the only way we're going to be able to make it through together in this, and not overwhelm the Texas Medical kind of Center as well. So,
yeah. Yes, I mean, you will hear, and I know you are hearing. You mentioned it, amazing consistency among medical professionals. There's really no reputable medical professionals out there saying we're way overdoing this, folks. We need to do something different. All of us, of course, understand there's many different competing priorities. There's many different issues that have to be balanced. We don't want to be in another Great Depression and have all the issues that happen, health related and others, which can happen in that scenario as well. But really, as we look at this from people's health right now, if we don't do this right the first time, it gets prolonged, it gets dragged out, and the economic side and the sacrifice we're all making together actually gets longer and worse. And so we believe strongly that, do it right the first time. A lot of work's going to have to be done. There'll be fits and starts and difficulties figuring out how to sort of let go of the restrictions and get to the next step. But we collectively, the American society is very, and the world as well, we're very. There's a lot of ingenuity, a lot of working for the common good. I have no doubt we'll sort those things out, but they're going to take time and patience for everybody to deal with. No question.
I know you're real busy, and I just one or two more questions, and then we will let you go get back to work, because I'm sure that's all you're doing these days is staying busy.
Yeah, there's not a lot of downtime these days.
No, I'm with you. Yeah. So one of the things that someone asked is, where would you point people for respectable things to read or to look at? We tell our people all the time, be real careful. It's, media can be very biased on all sides of your ideological spectrum, so you have to keep that in mind. But if a layperson was looking to read some materials or find some resources about this, or even a medical professional, we have a lot of medical professionals too that want to learn more or know, are there any ideas for that or places you would recommend they go?
Sure, that's a great question. Certainly, the CDC site's actually pretty good. You can go to coronavirus.gov. And, there's lots of resources and lots of data that are there. Johns Hopkins has an outstanding tracker. So if you want to look at numbers and look at some of that, just Google Johns Hopkins COVID tracker. You'll find that. If you want modeling, the IHME, that's the University of Washington, is a great modeling site. Google COVID IHME or University of Washington tracker, and you'll find that. And you can look state by state. You can look at the U.S. as a whole. You can look at the assumptions they're doing. And then, stick with either health institutions, so some of the major academic institutions like Houston Methodist and others in the Texas Medical Center or others around the country. Most of us have a lot of useful information on the site, a lot of pointing of good data, and then stick to the reputable news media. That doesn't mean there won't be some alarmist or sometimes some, so read everything with a grain of salt. But, whether you're looking at the New York Times or the Wall Street Journal, or you're looking at, major broadcast networks, or you're looking at, the big three kind of cable networks. I know they all come from things on a different political spectrum, perhaps. But when you look at the numerical data, the opinion data, use your judgment, obviously. But I'd stick with the reputable sources by and large. I may not always agree with some of the opinions and other things. That's useful to understand differing points of views with that. But mostly you're sticking with people who are sourcing their material. They're not publishing things that are, really factually untrue. I have seen a lot of bad information out there, particularly through social media and others. A lot of those have been pushed back, but there's a whole set of rumors around. I think it was Stanford, and later, or I forget if it was Hopkins or Mass General. I think it wasn't theirs, but people would quickly say, "Oh, look at what so and so at Stanford said," and it was putting out a lot of bad information. So go in eyes wide open and make sure you're thinking about where the sources are coming from.
Yeah, and someone else was asking about elective surgeries. A lot of those, I guess, are turned off because, like you said, to create space. is there a timeline on when those are turned back on for some people, or
Yeah.
do we know?
I'm hoping in May, but that's going to depend on a lot of things that we talk about. So when we're on that downside of the curve, putting aside the governor's order for a second, I'll come back to that, but just when we're on the downside of the curve, we're going to make a good judgment call about what's best for the individuals. Obviously, we don't want to defer things too long to where there's harm. And so all the decisions to delay elective surgeries they're not done in a fiat, just blanket way. They are done where we look at categories. We say, there's not a lot of good reasons to do this kind of surgery. However, there needs to be an exception because a clinician looks at that and decides the harm outweighs the benefit of delay, or the other way around. So when we get on the other side of the curve, that calculus will start changing. I say that with the caveat of, very rightly so, the governor made that order for the state. And so, of course, that'll need to be released. My guess is that may get released even sooner than we are comfortable with truly releasing everything. And we'll have a very judicious, thoughtful, stepwise process to bring those kinds of activities on.
Well, I want you to know, I think that everyone that responded back and knowing that we were going to be talking to you wanted to also express their support and whatever it is that people can do to be helpful to medical professionals for you and the support of you and everyone else down there. You just need to know that people are very, very appreciative. You see these videos of shift changes in New York or in Atlanta, and people coming out of their apartments on their balconies and cheering. And you guys really are on the front line of this. You are the modern heroes right now. And I hope that you will let everyone know on your staff. I know we're going to set up a time to talk with Bob Kidd and Stacy Auld about the pastoral care and spiritual care of this at some point. But just want you to know, on the medical side, there's so many people that appreciate all that you're doing. And I hope that you will continue to let them know that there's a lot of support out there.
That's right.
For you.
That means a great deal. And the people on our front lines, they truly are heroic. I mean, they come here, think of the hardships and the worries and the concerns and the anxieties and the exhaustion. It's not an easy time for the people on the front lines. But, what I hear over and over again is, this is what I trained all my life to do. This is what I was called to do from our colleagues. And it's really humbling and amazing to watch them just, do the right things and step together. And, for an institution like Houston Methodist, that obviously is faith-based, that has wonderful values, watching people live that out every single day. It's beautiful. It really is.
Well, having served on the spiritual care committee, just the way Methodist goes about the ethics aspect of making these decisions for families and the spiritual care is equally important to everything else that goes on. What, before you go, any question we didn't ask you, or anything that you'd lift up that you would think is important?
No, I think you asked, a lot of great questions. A couple other thoughts. There's a few other drugs out there that are being used, whether HIV drug like remdesivir, in which we're in a study and can also get compassionate use. That's a IV drug for really sick people. And then you hear a lot of the drugs, and I guess the one cautionary note to folks is, you'll hear a lot of optimism about some of these approaches, hydroxychloroquine, chloroquine, the malaria drug, Plaquenil, or rheumatoid arthritis. While we have some cautious optimism, we're far from certain that those work. And so we're working very hard to try and sort that out, try and figure out if it works. But there was also a lot of data about that plus a Z-Pak, azithromycin. The reality is the combination actually can be quite dangerous from a cardiac electrical standpoint, and is not one we really want to encourage people using as an outpatient. We might use it as an inpatient, but there we're able to monitor and care for somebody. So use caution as you interpret those kinds of things as well. But I think there's hope that some of those treatments may hopefully come out. And then the other thing we didn't talk about is the vaccine, and there is fast, furious work being done on vaccines. It's honestly a triumph of medical science that for almost a month now, pretty better part of a month, that we have vaccines in clinical trials around the world. Which that's 3 months after the vaccine showed up. The typical vaccine took 15 to 20 years to create before. And so it's very exciting to see how quickly that's working. But the reality is it still takes a long time, because eventually we're talking about, vaccinating hundreds of millions, if not really billions of people on the planet. And so to do that at that scale, you really have to make sure that you've gone through the right processes to make sure what you're giving them is safe. Vaccines are incredibly safe because they're so well studied. and because we study populations and figure out the best formulation and best efficacy. But that's why it's going to take 12 to 18 months to get a vaccine, and it's frankly going to be amazing we got one that quickly compared to the rest of recorded history. But that will ultimately be something that's very critical.
Well, Mark, can we just have a prayer with you real quick before we let you go?
I would love that. We'll take every prayer from everybody out there. Pray for all of us and pray for our population.
We really will. Let's just pray. Lord, I thank you so much for Marc Boom and for all of the leadership at Methodist Hospital and for all the leadership at the Texas Medical Center. I pray for the doctors and the nurses and all the healthcare workers, all the mental health professionals and spiritual care professionals, everyone that's working in every level and every aspect of the hospital work and public health. I pray for them, for strength, for their families, for safety. And Lord, we pray for an end to this virus and pray that you would give us the strength and the comfort and the wisdom and the discernment to be able to take the next right steps as we listen to these that you've gifted and given these skills and graces to help us make informed decisions. We lift up Mark to you, and we just pray for him and for his family in the name of Christ. Amen.
Amen.
Mark, thank you so much for being with us, brother. And you just got our support. Anything we can do, people here want to know if you need anything, or, we've got our folks that want to sew masks or whatever they can do. I mean, so just let us know. Okay.
We will. And we'll send you the information about the donating of the plasma. So
that would be great.
Great.
Thanks,
thank
brother.
You so much.
You be well.
Thank you.
Blessings.
Be well. All right.
Thank you.
What a great guy.
That was amazing.
Can you imagine being the president or CEO of a major hospital in a time like this? I mean, your job already is probably overwhelming, and then this happens, and your job is 24/7.
Yeah,
I would imagine.
Yeah, and he's having to take in so much information, disseminate it quickly to business communities, to pastors, to,
This is why he is such a great resource, and I'm really glad we were able to get him, because he is resourcing and talking with governmental leaders, business leaders, oil and gas companies, and nationally, but particularly in Houston, to help make decisions that we need to make. It's pretty amazing. He indicates that we are going to have some type of a surge in Houston. How bad that will be is going to be on all of us, and how seriously we take the social distancing. Well, Matt, what are you doing this week? Same thing you did last week and the week before?
I don't have no idea what that is, John. It's gone into a vault somewhere that I don't even remember. I know what I'm doing this week, though.
What are you doing this week?
So we've got some self-care stuff that we're doing with groups, both recovery groups and mental health groups in the church. And then I'm doing my Bible study on Friday. I'm preaching the sunrise service. It's Easter this week, which is just crazy. And so we're both preaching, but not on Easter Sunday.
Yeah, not on Easter Sunday.
And so that's really odd.
Well, but we're keeping social distance.
Yeah. That's right.
So do you have a link for Zoom or any way that someone can sign up to do that?
Yeah, sure. So, our Zoom Bible study on Friday at noon. You can get on Facebook and Hitchhiking Through the Bible. Also through the Chapelwood website. It's listed there as one of the resources on Friday. And then also we're doing a small group for folks who are kind of in recovery, but it's recovery from anything. So we've got a bunch of folks showing up there on Tuesday from 2 to 3 as well.
And all that's on chapwood.org.
That's right.
/stay connected. Well,
What are you doing?
I'm waking up in the morning at dark 30 to drive up to Norman, Oklahoma to move my daughter's dorm room, to empty all that, to bring it home. And that has to be completed in order for us to be officially checked out, and then to determine, will we be prorated room and board and all that? Who knows? I mean, it's just not something you expected to do on Holy Week, to be given a short little window when to come up and do that.
Get out.
it will at least make the rhythm will be different.
Yeah.
So that'll be unique. And preaching, we're participating in filming Good Friday service, and then also Easter services. at different times before Easter Sunday, which is really unique. But I've been thinking about the first Easter, and you had in John's Gospel, Mary by herself in the garden, or in the other Gospels, just a couple of the women that went to the tomb and found it empty.
Yeah.
And I always think about Mary trying to touch Jesus, and he says, "Do not touch me, for I have not yet ascended." And I think there's social distancing. Do not touch me. Keep your distance. But then also when they ran back to the disciples and they're gathered together in their small group in quarantine. And I'm thinking, this is going to be Easter like it was in the first time.
That's right.
For all of us.
That's right. Right.
Yeah.
And a lot of a deep sense of dread and unsuredness, right? And in the midst, Jesus continues to say, "It's I. Do not be afraid. It's me." Shows up in the midst of them. So, yeah.
Well, I'm glad we were able to do this and spend some time with Mark. I'm John Stevens.
And I'm Matt Russell.
And this is Pod Have Mercy.